Can you see it now?
No, ma'am. No. झाली का तू जॉईन करायची सुरू मीटिंग? अरे का क्लिक कर ना त्याला मी पाठवली तुला लिंक. नाही नाही परत एकदा बाहेर पड आणि परत कर. सगळी जॉईन झाले की ते.
मीटिंग नाही मीटिंग मधनं बाहेर ये. Now can you see?
Yes, ma'am.
Okay.
Now it is visible. Yeah.
Yeah.
Dr. Anuja? Dr. Anuja Bhosle, are you there? Shall we start meeting? Dr. Anuja? So good afternoon to all. I am Dr. Karli Gitanjali, Ayush Professor and Head, Maharashtra University of Health Sciences, Nashik. Today, we are going to discuss our first case of diabetes mellitus. As we know, diabetes mellitus is a metabolic disorder and it is involving inappropriately elevated blood sugar level. So it is one of the conditions having highest prevalence rate, that is 10.5. So we are going to discuss one of the important case, one of the global problem, and to discuss this case, we have PG scholar from Sumati Vaishya Ayurved College, Hadapsar, Dr. Anuja Bhojle. She is PG scholar from Kai Chikitsa department. So, Dr. Anuja, okay, she is not here.
Hello, Gitanjali ma'am.
Yes, sir.
हाँ, she have some problems. Just 2 minutes में try करेंगे.
Okay. Till then, we can start with introduction.
Yes, no problem.
So I will request Dr. Madhuri Kirloskar ma'am. She is professor and head from medical department, Dr. Vasantrao Pawar Medical College, Nashik. Ma'am, can you start with introduction of diabetes? Then we will discuss about case.
Okay, thank you, Dr. Karle. Good afternoon to everybody. And it's a pleasure to interact with all of you on this particular forum. And since diabetes happens to be my favorite topic, you've really done the job much easier for me. And thank you for inviting me here on behalf of your college and also MUHS. I thank MUHS for opening up such forums for good interdisciplinary discussions. I think they are the need of the hour, and especially with PGs coming in, they should also have a very good extended knowledge of various pathies and where exactly is the position that we stand on and how we can expand the scope in our interdisciplinary departments. So with that brief introduction, and thank you to MUHS and to Dr. Karle and to the presenting PG resident, I would like to just begin by talking a little bit about diabetes. And if you feel at any time that I am over taking too much of time, you can stop me at that point of time and we can just carry on with the case discussion. So till at the time that the PG resident joins us, I would continue with these slides. So as you rightly said, diabetes is a group of metabolic disorders as defined by WHO, characterized and identified by the presence of hypoglycemia and includes defects in insulin secretion, insulin action, and both, with disturbances in carbohydrate, fat, and protein metabolism. So when you come to the epidemiology of diabetes, as you rightly said, it's an exponential increase that we are seeing in the last 20 years or so. And maybe in the next 20 years, we're going to see a absolute pandemic. I would call it a pandemic because now the only thing that we know as a pandemic right now is COVID-19. But diabetes is an equal amount of pandemic. As you can see, most of the world is showing an upward rise, particularly Middle East and North Africa and Southeast Asia, which has, and India has the dubious distinction of having the highest number of diabetics in the world, very close to China. I don't know. I think we need to not follow China in this and find out ways in which we can fall behind China, at least in the matter of diabetes is concerned. So projected future trends are very exponential, 51% increase in the next 10 years, 20 years, from 463 million to 700 million. And India will see a jump from 63 million at present to almost 120 million. So almost 1 in 11 adults will have diabetes, and 1 in 6 adults with diabetes in the world will come from India. As I said, these are not figures to be scoffed at, but we have to be really very careful in empowering our patients, in understanding the disease, trying to see which treatment would help the patient most in reducing the complications that we do not want, and one of which we will discuss now. So the tragedy is that the large number of Indian population actually do not attain treatment targets. As you all know, 7% is the holy grail of HbA1c, and most of our patients are not achieving that despite our best efforts for various reasons, which we can take in the discussion that will follow. So all of you know these are the structure of the pancreas, the alpha and the beta cells, and the insulin is secreted from these cells, and glucagon from the alpha cells from the islets of Langerhans. Now, glucagon is a hormone which is released by the pancreatic alpha cells in response to low blood glucose. So glucagon comes in very handy when patient has very severe hypoglycemia to your treatment, and that is the time we give injectable glucagon, and that itself raises the blood sugar. So again, insulin acts through the medium of the GLUT4 receptors. These are glucose transporter unit receptors, and as a result of which insulin is accepted into the cell. Now, this is something all of us must know. Insulin acts on 3 major organs, and one of that is the liver, the second is the muscle, and the third is the adipose tissue. Now, the complex interaction between these three, glycogenesis, glycogenolysis, that is breakdown of glycogen, and gluconeogenesis, which is formation of new glucose through proteins and through the diet that we take. Muscle, what does insulin do? If you have good insulin and muscle tone, it increases the glucose uptake. So less glucose is there in the blood, increases amino acid uptake, and protein synthesis is encouraged. Same thing happens in the adipose tissue, adipocytes. You have an increase in glucose uptake, increase fatty acid synthesis and uptake, and decrease in lipolysis. So all this is the effect of insulin on these 3 vital organs, all of which is responsible for causing increase in blood glucose. Another important organ that has come into play now in glucose homeostasis is incretin hormone. Incretin is the hormone that is released by our gut, and this hormone plays a very important role indirectly without influencing the pancreas to cause increased glucose uptake, cause a satiety, and decrease in glucose output. So this is a drug, the DPP4 that we know today, because that's a DPP4 enzyme which acts on the incretin. And that is the action of the DPP4 enzyme to increase the glucose uptake in the muscle and decrease it in the liver, but not through the pancreas, through extrapancreatic mechanisms. So basically, if you see what is the pathophysiology of type 2 diabetes, it's an increase in carbohydrate intake. Unfortunately, all the Indian diets have a very high carb intake, whatever that we eat. So we have to try to focus, jala apan manto badalti jeevan shaili. So therapeutic lifestyle change is something that we need to encourage. Decrease in peripheral glucose uptake that we saw earlier, increase in hepatic glucose production, and decrease in insulin secretion. All these together are responsible for the type 2 diabetes that is so common. Again, the incidence of type 2 diabetes in our country is almost 95% versus type 1 diabetes, which is only about 4 to 5%. Now, the problem in India is that this complex mechanism of obesity, especially abdominal obesity, the thin, lean phenotype that we call, as well as the diet and the sedentary lifestyle, all put to play in the pathogenesis of type 2 diabetes. So this is a slide I think all the PG students should remember if they are talking about type 2 diabetes, and that is the ominous octet. The ominous octet is that where every organ is almost involved in the pathogenesis of diabetes. So as I said, it's alpha and beta cells of the pancreas. Then you have the gut and the intestine leading to incretin effect, increase in lipolysis in the fatty acid tissue. Now the kidney is also shown to have a very, very positive role in causing increase in glucose reabsorption and thereby increasing blood glucose. And kidney is also an organ that has been targeted in the drug therapy of type 2 diabetes with the new kid on the block, that is the SGLT2 inhibitors. Then you have decreased glucose uptake in the muscle, neurotransmitter dysfunction, and here you have a drug called bromocriptine, which is supposed to act through the brain. Again, increase hepatic glucose production in the liver. So metformin is a drug which is very useful in these patients. And finally, as I said, increase glucagon secretion through the alpha cells. So this is something, the ominous octet causing pathogenesis of diabetes, that everybody should remember at all times. Now, what are the factors that contribute to diabetes, type 2 diabetes? Mainly, we're talking about type 2 diabetes, and that is insulin resistance as well as beta cell dysfunction. Now, changes in incretin hormones system have also been seen, as well as associated factors like increase in hepatic glucose output and adipocyte dysfunction, which I have already showed you in this previous slide. So those of you who have joined in late, just remember that this is the ominous octet that changes everything for diabetic patients. Insulin resistance is something that we need to understand, and that is because almost 70% of all type 2 diabetic patients have some degree of insulin resistance. So if the patient has insulin resistance, what is going to happen? He's going to need higher and higher doses of drugs. And finally, when it comes down to using insulin, he will need higher and higher doses of insulin unless you target the insulin resistance through a good lifestyle change, through weight reduction, through diet, etc. Obesity is one of the important factors that is responsible for insulin resistance. The second important factor is insulin deficiency. So if you see this graph that is being put up, then you realize that it's a combination of insulin resistance that goes on rising and a fall in insulin production that occurs over time that is ultimately responsible for increase in fasting glucose and thereby postprandial and development of diabetes. So you have high insulin resistance, low insulin production, high fasting glucose and postprandial glucose, all of which are components of frank diabetes that sets in over time, over years. So in fact, pre-diabetes is a segment that needs to be addressed today, and that is where the entire focus today has shifted from treatment of diabetes to treatment of pre-diabetes. And we need to understand that the green graph that you see in between is the pre-diabetic, when the insulin resistance slowly starts rising and the insulin production actually is normal at that stage. So these are the patients, the obese patients, patients on steroids, patients with gestational diabetes that we need to target. Causes of insulin deficiency are many. You have genetic and environmental factors, and a combination of this causes a decrease in beta cells and decline of beta cells to secrete insulin, causing glucotoxicity and lipotoxicity, both of which causes destruction and irreversible damage to beta cells. So finally, what is the end result of diabetes is that the pre-diabetes, you can say, is a beta cell fatigue, and diabetes is actually beta cell death. So some degree of irreversible destruction of the beta cells has already occurred when a patient is detected to be a frank diabetic. And hence I said that the focus should shift from treatment of diabetes to treatment of pre-diabetes, and probably we will help our patients a lot by preventing the micro and macrovascular complications which occur with diabetes. As now, this is something that I wanted you to have a look. This was the older classification. All of us know this. Type 1, type 2 diabetes, gestational diabetes. Type 1 diabetes is again of two types. Idiopathic and autoimmune diabetes is also type 2 diabetes, which the causes of which we have already seen. However, there is a recent classification that has come, and somebody wants to know the recent classification. So these are the recent classifications. They're classified into type 1, type 2 diabetes, hybrid forms of diabetes. So very often we see adults who come to us with ketosis, Or we see younger children who are obese and not really needing insulin. So now we should get away from that thing that every young patient who comes to you needs insulin, and every old patient who comes to you will be doing well with oral anti-diabetics. It is not so. And there is a lot of intermingling. There is a lot of merger of the two components. And this may be because of genetic components, or it may be because of diseases of the exocrine pancreas, like pancreatic insufficiency, endocrine disorders like thyroid, like cortisol deficiency or Cushing syndrome. Certain drugs like steroids, if used for a long time, can give rise to these forms of interconnected diabetes. Infections. In any source of infection, patient may need to take insulin for a temporary period. So these are temporary stress induced situations where patients may need to take insulin for that period, and after that he may go on to tablets again. And then there are some varieties of immune mediated diabetes called LADA, where again, as I said, that you may have to give insulin even if the patient is a type 2 diabetic. Unclassified diabetics, where you're not sure, he has a combination of type 1 and type 2. And the best thing is to first put the patient on insulin and then see how it goes. And finally, hypoglycemia in pregnancy. This is again a problem that we're facing today. Almost 12 to 15% of all pregnant patients with who come to us with diabetes have have to deal with this problem of hypoglycemia and its sequelae. So as I was telling, type 1 incidence is only 5 to 6% in India, but it is autoimmune or idiopathic and is triggered by environmental factors, most often a viral infection, or can be a combination. Whereas type 2 is what we are dealing with. It can be older age group, younger age group. It can be related to your family history, to various genetic factors like the MODY 12, MODY 7, history of gestational diabetes. So once a patient has gestational diabetes, it is very, very likely that in the subsequent years, this woman will go on to develop frank type 2 diabetes. And impaired glucose tolerance, or what we call as pre-diabetes itself, is a story that needs to be understood, because if you control pre-diabetes, if you control impaired glucose tolerance, then you would be putting the patient on the path to prevention of type 2 diabetes later on in life. So these are the major risk factors. And I think each and every patient over the age of 30 years, as of today, should be screened for diabetes. We'll see how to do the screening test a little later, but these are the risk factors: age greater than 45 years, very strong family history, weight. As you know, we calculate the BMI, right? The weight in kg upon the height in meter squared. So any BMI more than 25, you must look out for diabetes. Then certain races are very prone. So these are African American races, Pacific Islander, and of course, Southeast Asia, Indians for that matter. Any impaired glucose tolerance or impaired fasting glucose, hypertension, hypothyroidism, dyslipidemia, all coexist with diabetes. So any patients with hypertension, you must check his sugar. Any patients with cholesterol, it's not enough to treat the cholesterol, we need to check the sugar. History of gestational diabetes, or any woman with a birth weight of 9 pounds. So don't be happy if the child's weight is more than 4 kgs. You need to look out for impaired glycemic status in the woman, because this is a very important red flag. Polycystic ovaries, we're all the time hearing about this terminology, more related to insulin resistance. I already told you about the genetic mutations, the MODY 12 and the MODY 7. And one important thing that has come into play, and that is gestational hypertension is also associated with diabetes, as also certain psychiatric illnesses like depression and schizophrenia. So this is also called as type 3C diabetes at times. So if you don't want to get complicated, you can just put it in associated factors with diabetes. Just keep a lookout for them. So the progression and development, we've already talked what happens to the insulin and what happens to the insulin resistance. And this over a period of time, you develop beta cell fatigue, you develop increased insulin resistance and hyperglycemia. So this goes from normal to pre-diabetes to diabetes. What are the signs and symptoms that we should look out for? Remember, the first and the most important thing I would like to make, and this is a blanket statement I would like to make, that 50% of diabetics who are detected for the first time may have no symptoms, and in fact are detected on a routine health checkup that they undergo in one of the corporate setups, or if the patient wants to know, my uncle is a diabetic and I've been feeling a little lethargic and dull, and is it okay if I do the sugar? Sure, each one of us should do the sugar, because all of us are prone to developing this disease at some point or the other. The classical symptoms, of course, we all know: polyuria, polydipsia, polyphagia, weight loss, weight gain in case of type 2 diabetes, blurred vision, lower extremity paresthesias, frequent genitourinary infections, headaches, unexplained weakness, tiredness, lethargy, etc. All these and so many more may be features of. So there is no one system that may be involved. Diabetes is a multifactorial involvement, and you can have symptoms related to any of these diseases. These are only the classical symptoms. But once again, I would like to say 50% of patients may not have any standard specific symptom that is described above. It is up to us to weigh what is this BMI, what is his family history, what are his genetic factors that are coming into play, what is the kind of diet he's taking, and advise at least a 6 monthly, if not a yearly, blood sugar. I think that is absolutely essential, and most of the time, this simple test that can be done in your home through a glucometer, it can be done in the hospital by a random glucose, is just not advised because nobody thinks of it. And that's a sad thing, because today in our country, we are facing this epidemic, and across the world, this pandemic. COVID was given a lot of importance. Diabetes is still not given that much of importance, though it's going to cause many more and much more complications in due course of time. So we generally accept the IDF definition and the WHO definition for the detection of diabetes, and one positive test confirms the diagnosis in a symptomatic patient. If the patient is asymptomatic, you can do a OGTT, that is an oral glucose tolerance test, or you can repeat a second test. Let us see what are the levels. So as I was telling you, pre-diabetes is something that we need to look out for. And the pre-diabetes fasting glucose levels are between 100 to 125. Frank diabetes is more than 126. 2-hour postprandial glucose level will be somewhere between 140 and 199, and frank diabetes would be more than 200. If you have taken a random sample, the patient has come to you because he just is a walk-in in the clinic or in the hospital, and he's symptomatic, says, I don't feel well, and if the sugar at any time is more than 200, then that suggests diabetes, or the HbA1c is more than 6.5. Now, pre-diabetes, the HbA1c that we take into consideration is between 5.7 to 6.5. So 6.5 is the HbA1c more in excess, beyond which we classify it as diabetes. And the ideal care that we take is to achieving a target of HbA1c between 6.8 to 7. Because across various tests, it has been proved that by minimizing this HbA1c to 6.8 to 7, we can prevent the micro and macrovascular complications. I've already told you what the pre-diabetic values are. So this is done, the oral glucose tolerance test is done whenever there is a doubt. You do a fasting, then you give 75 grams glucose, and then 2 hours later, you check the blood sugar level, and it should be within the parameters that if you want, you can once again go through this. So this is the values that tell us pre-diabetes and diabetes. So American Diabetes Association accepts all these guidelines done through the standard test. HbA1c, for us to do, it should be done in a proper standardized lab. There are many HbA1cs, and they cause a lot of confusion. So it is better to use standard lab and standard methods for HbA1c, and that will erase many of the complications and the confusions that arise. This is how we monitor diabetes, because diabetes is not enough just to know that, theek hai, I've got blood glucose, but then what? So the various ways we can monitor diabetes is by doing it through a self-monitoring of glucose, which can be done at home. Glycosylated hemoglobin, which gives you a value of last 3 months of average blood glucose level. And the other tests that have recommended when the patient first comes to you is a blood pressure, and this should be done at every routine visit and at least annually. Then you must check for cardiovascular risk factors, like check the smoking status, alcohol, BMI, lipids, annually at least. Eye examination, and of course ECG. Eye examination should be done at time of diagnosis, and then annually if the patient experiences any blurred vision or anything, then it should be even done in emergency at any time. Kidney function tests, you have to do it annually. If there is any doubt of microalbuminuria or proteinuria or disturbance of creatinine, then you can even do it once every 6 months. Hemoglobin and ferritin levels also should be measured. And foot examination, since we're going to talk about a neuropathic case, I think I will leave this to discussion, which we will take up. So your HbA1c targets, I've already told you, good target is between 6.8 to 7. All patients will not accept a value of 6.5 because it can cause tremendous hypoglycemia. But 6.8 to 7 will allow you enough margin to prevent all the complications, the dreaded complications and the morbidity that we see with diabetes. So a plethora of drugs are available to us today to treat diabetes. We have various groups in the form of monotherapy. I think one standard drug that should never be forgotten in type 2 diabetes is metformin. Because start with metformin and then you add on any of the other drugs like the SGLT2. Today there's been a sea change. We all grew up with sulfonylureas, but today it is the SGLT2 inhibitors and the DPP4 inhibitors which have taken over the conventional sulfonylureas for the cardiovascular, renal benefits, advantage of no weight gain, and also hardly, if any, hypoglycemia. So these are the various group of drugs that can be used. As I said, the GLP-1 receptor agonist, and you have the new kid on the block, which is creating a real blockbuster, and that is semaglutide. Then SGLT2 inhibitor, which are also known as the glyphosate, the DPP4 inhibitors, glitazones, sulfonylureas, and then you come to the basal insulins and followed by complicated insulin regimes. All of these drugs alone or in combination will help you to control diabetes and bring the HbA1c to the target level of 6.8 to 7. As I said, never forget metformin. Metformin is at the head, the top of the pyramid, followed by all these drugs, depending on how comfortable. And one more thing that I want you to remember is that no one size fits all. We have to remember that it is not one drug or one particular type of treatment modality that is going to help, but we have to individualize therapy. We have to individualize it according to the patient comorbidities that we saw, whether he has diabetes, whether he's heart disease, whether he's renal disease, etc. So it's not one formula for diabetes, but we need to see under which umbrella the patient falls into, and then find the best combination out of all these drugs that are available to us. So your targets are dependent on the age, on the duration of diabetes, the various comorbid conditions. What is the risk of hypoglycemia and what will hypoglycemia do to this patient? Patient motivation, adherence, and habits. So the treatment guidelines, I've already told you, I don't think, so this is how it goes. And I think this is again a slide that you all should keep in mind. We don't insist on HbA1c 7 for everybody. So if you have an older patient with borderline renal disease, with a tendency to hypoglycemia living alone, don't try to be very stringent. You can increase the HbA1c to 7.5. This is the dual monotherapy.
मोबाईल वरनं झालीये मी जॉईन.
Sorry. So these.
Hello. Ma'am, I have certain technical issues.
Okay.
Please continue this meeting and
Okay.
yeah, I will be connected with you, but please conduct this
Okay.
meeting.
So remember that type 2 diabetes management is very, very complex. You have a lack of 24-hour control. You see, I have so many patients who come and say that my morning sugar, doctor, is 145, my afternoon sugar has gone to 320, I've hardly eaten anything. Or they'll say my night sugar, you know, at 12 o'clock at night, I got up with intense hunger. And that's because my blood sugar, when I checked at that time, was 65. What do I do now? How do I adjust my drugs? So this is one problem. And lack of long-term control. As I told you, hardly 30 to 40% of Indian patients have a good HbA1c over a prolonged period of 5 to 10 years. The rest, all of them hover between 8 to 9.5. And this is the sorry state of affairs, despite our best efforts for various reasons. We can discuss it. Complex dosing. You make the patient say, take this before breakfast, take that after lunch, take this before dinner. He's never going to remember. Imagine at such a point, try to put yourself in the patient's shoes. Try to empathize with the problem. And you should try and make sure that the patient doesn't have more than 2 or 3 times that he has to take the dose. Then again, drug-related cardiovascular and renal hepatic dysfunction. You have to consider all this. Hypoglycemia is a very, very real possibility, a big problem, and it can even lead to certain life-threatening conditions. So we need to consider hypoglycemia. Weight gain. Here we tell the patients you need to lose weight. But most of the drugs that we were giving earlier, like the sulfonylureas, the glitazones, all of them cause weight gain. So the poor patient is trying to lose weight, and here you're giving a drug which is making him put on weight. So where does this balance? So now you have drugs like the GLP-1 receptor agonist, as I said, the new kid on the block, which is creating a lot of waves. You have SGLT2 inhibitors and DPP4 inhibitors, which help a lot in combating this. So we need to treat the whole elephant and not just in bits and parts. So it's not enough that the patient came to you for weakness, so you just give something for the weakness. If patient has an eye problem, you treat the eye problem and don't look at the foot. And if the patient comes to you with a cardiac problem, you ignore that cardio-renal problems are the most common that go hand in hand. So these are the various treatment options that are available to us. Biguanides, metformin, as I told you, is the bulk, and these are the advantages of using metformin. Sulfonylureas, which were originally used quite a bit about 10 years back, now with the first generation, second generation, third generation, but now with the advent of newer drugs, glitazones are the other drugs. Problem is weight gain and edema with glitazones. So again, these are some drugs which may be used only in specific type of patients. But it's the incretin mimetics, the GLP-1 receptor agonists, and the DPP-4 inhibitors, which have really revolutionized treatment in various ways and which has enabled us to go that extra mile. And since I don't have time to discuss all this with you in detail, I'm just going through it a little fast. The next are the prandial glucose regulators, where you want only for some people are used to consuming very high carb meals. For these people, the prandial glucose regulators do come into help, and these are nataglinide, repaglinide, etc. And the alpha glucosidase inhibitors like acarbose, voglibose, all these, which help in preventing the rise in blood sugar. And finally, we come to insulin, which is our mainstay. Whenever everything fails, as I said, lakh dukho ki ek dawa chahiye, to it is insulin. So it helps you to combat the sugar. It helps you to build up your muscle and build up your body strength, as well as it targets the micro and macrovascular complications. You have a number of insulin preparations, which is beyond the scope of this lecture. But if you want one slide which tells you the whole story, then it is this slide. So this tells you where it lies in terms of weight, renal effects, in terms of GI problems, heart failure, cardiovascular disease, bone problems, and even malignancies. So if you see one drug, can you see one drug which helps most of these problems? Can you tell me one drug which is addressing almost all problems? And there is no one drug. And that is why it's the combination of, it's a combination, a dual or triple therapy that is really, really useful. So with that, I stop my screen sharing and you can take it from here.
Sorry to disturb, madam. Madhuri, madam.
Yeah. Yes, yes.
Please don't leave that meeting.
Okay.
कार्ले मैडम having some issues there. MUHS में लगभग सभी लोगों को प्रॉब्लम आया है कुछ तो भी.
Okay.
So you are the co-host here.
Okay.
And if you leave that meeting, the meeting is going to be disconnected completely. So please don't.
So what I can do is, since I'm
you are the co-host now here.
Okay.
So next to madam, you are the you are host here, na? So if
okay,
host,
so what we'll do is let us take
meeting
the case.
is continue. Meeting is continuing now.
Okay.
And now here again that case Anuja is representing here.
Fine. So let Anuja come and present.
Yes,
the case.
yes.
Yeah.
Yeah, madam.
Hello, ma'am. Ma'am, just one request to you.
Yes.
There is some technical issue in online meeting for Dr. Gitanjali Karle, ma'am. So she suggested that you are now the co-host. So please don't leave the meeting.
No, I have not left the meeting.
Hello.
Don't worry.
Yeah.
I'm waiting for the PG resident to present the case.
Okay,
Hello,
no,
ma'am.
ma'am. Yes.
Hello, everyone.
Hello.
Am I audible?
Yes.
Ma'am, should I start my case presentation?
Yes.
I'm sharing my slide.
Can you introduce yourself before you do that, so that we know where are you
Yes, ma'am.
from, what are
Yes.
you doing, which year are you in?
Yes, ma'am. Good evening, everyone. Myself, Dr. Anuja Bhojne from Sumatibai Shah Ayurved College, Hadapsar. I'm third year PG student under the guidance of Dr. Yogesh Patangare, sir. So today our topic of case presentation is diabetes mellitus. I'm presenting a case. The case is a 54-year male patient having weight 88 kg came to OPD. At that time, the chief complaints were weight gain since 1 month, polyuria, polydipsia, and tingling sensation in lower limbs since 10 days, generalized weakness since 4 days. And past history, he was known case of hypertension since 12 years and known case of diabetes mellitus since 2 years. Family history, no any family history of DM or hypertension. And drug history, he was on irregular medications, tablet metformin 500 mg twice a day and glimepiride 2 mg once a day. And for hypertension, he was taking tablet telmisartan 40 mg once a day. And about addiction history, he was tobacco chewer and smoker, cigarettes daily, and occasional alcoholic since 8 years. On a physical examination, weight was 88 kg. Actually, that is 88. It was a typing mistake. Height was 156 centimeter. BMI about 32.9. Pulse was 82 per minute. BP 130 by 80 mm of Hg. Iris was clear bilaterally. CVS S1, S2 was normal and audible. CNS was conscious and oriented, and no other significant findings were there. Then Ashtabit Pariksha, Nadi was Vata Pittash, Mala Prakrut, Mutra Aniyantrit and Nakta Mutrata was present. Jiva was Sam, Shabda Spashta, Sparsha Anushna Sheet.
स्थूल. Then Dashvit Pariksha, Dushya, all 9 Dushyas of Prameha, that is Rasa, Rakta, Mas, Med, Shukra, Oja, Ambu, Vasa, and Lasika. And Desh Sadharan. Bala was Heel. Kal, Sharat Kal, Anal Samyak, Prakriti was Kapha Pittaj. Then Vaya, Sattva, and Satmya was Madhyam. And Ahar, he was taking mixed diet, Mamsahar and both veg and non-veg. And differential diagnosis, diabetes have differential diagnosis like DK, diabetic ketoacidosis, diabetic neuropathy, then endocrinal disorders like acromegaly, Cushing syndromes, pheochromocytoma, then hypothyroidism, and diabetic hyperosmolar syndrome. At the time of visit, patient came with reports. BSL fasting was 212.2 mg per dl, postprandial was 261 mg per dl, HbA1c of HbA1c 9.8%, urine fasting and postprandial glucose was present. And in diabetes mellitus, we should do fasting BP, then urine sugar fasting BP, serum insulin, HbA1c, and C-peptide levels are other investigation to be done. Thank you. This was the case of the patient came to our OPD.
Anuja,
Hello.
right? You are Anuja.
Yes, ma'am.
Yes, Dr. Sharma, you can.
Yeah, madam. Anuja has representing her case. Just there is a symptomatology and so on.
Yes.
So expert opinion from that CSMS college, Dr. Naresh is there. Dr. Naresh Nimbalkar, sir.
Yes, sir.
Yes, sir. Please continue for what exactly you want to say and what exactly she has to be prescribed and so on.
Okay, sir.
So later on, I come for my homeopathic point of view and then we go for further whatever. As if madam continued for that case or that presentation, then we will continue.
Yes, sir.
है ना?
Yes. Hello.
So here मला
yeah.
वाटतं आता याच्यामध्ये आयुर्वेदिक याच्यानुसार तिनं फक्त केस काय आहे कशी आहे हे सांगितलंय औषधोपचार आणि त्याच्यानंतर प्री अँड पोस्ट व्हॉट शी हॅज टू बी प्रिस्क्राईब व्हॉट शी हॅज टू बी ऑब्झर्व दॅट इट्स नॉट गिव्हन देअर.
Yes, sir. Yes, sir.
Yes,
So
sir.
I will
Please.
highlight on the treatment part, sir. Yes.
Yes, sir. Yes, sir.
Yes, sir. Thank you so much, sir.
Yes, sir.
Good evening. Myself, Dr. Naresh Nimbalkar. I am associate professor in the Kai Chikitsa department, that is medicine department in CSMS, the Ayurved College, Chhatrapati Sambhajinagar. So she has the student has Dr. Bhojne has presented her case nicely. So when we observe the case of diabetes mellitus as according to the modern medicine, we consider as a prameha. And diabetes mellitus, when we compare diabetes mellitus with prameha, it is one of the type of prameha. There are 20 types of prameha, and diabetes mellitus is the type of Vataj prameha, according to our science. So prameha is one of the among 8 Maharog disorders needing serious concern and explained as important among Anushangi Rog, that is chronic disorders, manifested as these are the symptoms. According to Ayurveda, when we compare Ayurvedic complaints and modern complaints, these are mostly polyuria, polydipsia, polyphagia. And when you go through the case study, so we see all the factors, that is hereditary factors, some aggravating factors like addictions, substance abuse, also having patient, and then patient is not taking the proper medicines, and due to his sedentary lifestyle and due to his addictions, he has also gained the weight. So now he is diabetes, he is hypertensive, and he is according to BMI, he is obese. We consider him as according to Ayurveda as stolya. And when we go through the parameters of the patient, so weight is 80 and BMI is calculated. Still, the blood pressure is 130/80. It is maintained by the telmisartan medicine. So regarding, so still there are no complications of diabetes mellitus or prameha, as we see the Ashtavid Parikshans, 8 examinations of the pulse patient, that is pulse, urine. So according to Ayurveda, it is considered as Prabhut Avilmutrata. That is considered in our granthas. So again, going to the case, Dashvit Parikshan and Ashtavit Parikshan, we go through the dosha and dushya. As we say, dosha dushya samurchana janito vyadhi. So according to the dosh, tridosha, vata, pitta and kapha. Predominantly we see the kapha predominance in the case. And when we go through for the dushya, we see 10 dushyas except asti, that we can correlate with the bones. Asti dhatu we consider as. So those are also involved. When we go for the patient's dietary habits, or as per Ayurveda, we consider as a Agni, how he's having digestion. So his Agni is Mandagni. So he's having doing all the apathyas. Means he's taking all the contraindicated things which are explained in the granthas regarding this. So differential diagnosis is according to the model, and these parameters are HbA1c is uncontrolled, poor control. So in diabetic case, fasting is 212, postprandial is more than 250, and urine fasting is present, and urine postprandial is also present. So when we go regarding the Ayurvedic part in treatment, regarding treatment, so we consider in 3 major factors. First one is the case patient is having newly diagnosed case of diabetes mellitus, newly diagnosed case with or without conventional medicines, not changed since last month. So blood sugar fasting more than 125, postprandial is more than 140 to 250, and HbA1c is 6.5. We consider as a first group regarding Ayurvedic part treatment. Then second case is pre-diagnosed with conventional anti-diabetic medicines or oral hypoglycemic agents. So blood sugar fasting more than 125, and less than 250 blood sugar, and HbA1c 6.5. And third part is chronic onset of diabetes mellitus and with the complications. So when we regarding the case, so these are the most of the symptoms which are explained in our granthas. Those are present. That is increase in frequency and quantity of urine. That is Prabhuta Mutrata. So when we consider as a polyuria means how many times. So when we consider is at least more than 6 times or more than 6 times per day, we consider as a Prabhut Mutrata polyuria. Then polydipsia is complaint also. Avil Mutrata, Nakta Mutrata means nocturia. So he's having polydipsia and polyphysia. These are the complaints. Then Hastapadatalo Daha, tingling sensation or peripheral neuritis. Then increased coating or secretions in eyes, ears, nose, mouth, and tongue. This we call as a Dantadina Malatyatva. These are the cardinal symptoms, 9 symptoms that I will just repeat shortly. Prabhuta Mutrata, Avila Mutrata, Nakta Mutrata, Atyadik Pipasa, Kshuda, Daurbalya, Mukha Madhurya, Hastapadatala Daha, Ati Garma Pravritti, excessive sweating, and Dantadina Malatyatva. That is, as I said, increased secretions over these eyes, ears, nose, mouth, and teeth. So these are the typical case as we see. And when we treat this case, we have explained regarding the treatment shloka, or basic concept regarding Stula Pramehi and Krusha Pramehi. That is patient who are obese and patient who are thin. So in case 2 different parts. In this case, when we see there is a more concern or more need of Panchakarma treatment, that is Shodhan Chikitsa. We consider in 2 groups mainly. Shodhan Chikitsa, that is one type of purification. Shaman Chikitsa means we use rasaushadhis, we use decoctions, we use tablet, different forms. We use the single drug medicines. We use for these cases according to the symptoms of the patient. We have seen all the parameters regarding blood sugar level, HbA1c. So we prescribe Panchakarma treatment. Panchakarma treatment, Shodhan Chikitsa is firstly needed in the case. Shodhan Chikitsa, we give induced emesis, that is we call as Vaman, and purgation. We give strong laxative to the patient, but according to the status of the patient needs to give an Pachan, as is Agnis Manda and Dhatvagni disease we call it. So we use Langhan patient, we advise him to take some dietary changes regarding 3 to 5 days until he develops the typical symptoms of langana. Means his appetite increases, he feels fresh. Those symptoms when we compare, so we give him medicated gurta to the patient. That is, we mostly prescribe tikta gurta near about 3 to 5 days. And after completing the 3 to 5 days cycle of increased dose of this tikta gurta, starting from 30 ml, 60 ml, 90 ml, as per the patient develop all the signs and symptoms of samyak snehana. So we advise when them we prescribe snehan svedana and we give the woman with madanfal, or same process we advise the patient to take virechana treatment. This is the first line of treatment we can advise in the patient, as the patient will lose the weight, so he will also feel good. And according to the parameters which we advise to the patient, pathological investigation, there will be much more parameters will decrease. Then second, we will advise the patient with the medicines. So typically in the granthas, it is advised as Meheshu Dhatri Nisha. This is a drug of choice in Ayurveda. Dhatri and Nisha, we advise the patient. Then second drug of choice, according to Samprapti Bhanga, Kleda, we advise Chandraprabha tablet. Then we advise the patient with Arogya Vardhini tablet. We advise some basmas. In this case, we Vanga basma. Then we also advise some Tapyadi Loha in such case. As we advise these medicines, those are some anupanas we give. That is one type of vehicle which will help medicine to get absorbed fastly. So the drug of choice, Dhatri Nisha, we will advise the patient in the such case with advice in empty stomach, and it is acting on the 3 doshas. So this kind of treatment, according to the symptom, in this case, we will also advise according to the some sign and symptoms, Pravala Panchamrut and Chandraprabha Oti. Pravala Panchamrut is also act as a Pitta Pradhanya Janna Dosh. As we advise the patient with the Panchakarma, Shodhan Chikitsa and Shaman Chikitsa, we also advise in some dietary changes in the patient's daily routine, and also we advise some exercises in the form of heavy exercises. Firstly, the most benefited thing is walking, brisk walking, near about 40 to 45 minutes brisk walk, and some kind of asanas we advise the patient, and also we advise some kind of dietary changes. So according to the diabetes mellitus, and in this case, we advise the patient. So advise the patient with total duration of 60 minutes exercise is advisable in such case. So we need 30 minutes of physical activity and 30 minutes of pranayam and relaxation to be practiced at least every 5 days in a week. So it is advisable in such cases. In some asanas, we advise Pavan Muktasan, we advise Vajrasan, we also advise also benefited exercise in such cases is Surya Namaskar. We increases step by step. That is 10 steps past Surya Namaskar, 6 rounds, then 12 steps of slow Surya Namaskar, 1 round. Gradually we increases the Surya Namaskara. Then we also advise the asana. It should be done at least for the 1 minute. The position should be taken. That is Trikonasana is advisable. Then Parivrutta Trikonasana is also advisable. This is the posture, standing posture exercise. Then we also advise supine position, that is Pavan Muktasana. We are mostly advisable and can be easily done. There are some do's and don'ts. We have to check hernia and all this if we are advising Pavan Muktasana. In prone position, we advise Bhujangasana to the patient. Then in sitting position, Mandukasana. So these are the some exercises we are advising in the exercise form. And important part also, that is pranayam. 2 types of pranayam mostly advisable in such case. That is Nadi Shuddhi pranayam and Brahmari pranayam. We can advise in such case. And also the last part, when we go through all the signs and symptoms and whole history taking part, there must be some psychological part. But that is also, as a madam also put some stress on the psychological factors, we advise meditation in such cases for stress management and for deep relaxation and silencing the mind. That is cyclic medications, meditation we can advise in such case. So these are the things we can advise in such case. And the last but not the least part is the dietary changes. What patient should take. Also, mostly patients are asking regarding doctor what should be eat. आम्ही काय खावं किंवा काय खाऊ नये. मग स्वीट मध्ये काय खावं, गोड काय खावं, मग फ्रुट्स कुठले खावं. So one important factor regarding diabetes mellitus, who are prone or who will develop diabetes in future is one of the major factor developed in these days. So intake of sugar, those who are taking the sugar, that may be in sulfur, it prepare chemical sugar, that may be sulfur sugar, that may be brown sugar. They are most probably get chances of getting diabetes mellitus in coming future. So we have advising the what agri good to the patient or to the healthy individual, those who are taking, because now when we are seeing the diabetes mellitus, that is gestational or the juvenile or all these things, there is major role or major factor of sugar, because the sugar is used in the most of the forms, starting from childhood to adult. They are habitual, means when we are just having observations regarding the addictions. So we see tobacco, we see all these patterns. So we assume or we can conclude that it triggers one of the centers in the our brain. But when we consider as a sugar, when we eat sugar, it stimulates complete brain. So now it is the time that is advisable that it should be written. The sugar is injurious to the health. This is the most alarming sign in the scenario that it will lead. Now, time has come that 2025 will be the capital of diabetes mellitus. India will be capital of diabetes mellitus. So these are the alarming factors which we can prevent. The both management, according to the Ayurveda, preventive management and curative management. Preventive management in case of pre-diabetes cases, we are diagnosed with pre-diabetes and we follow some diet changes. We are going for the panchakarma, shodhan chikitsa. There is less possibility that the person who is pre-diabetes will land into the diabetes case, and also curative part with panchakarma therapy and with medicines we can control his, because most of the things when it will be the patient will be considered as a normal, his values will be normal, his fasting blood sugar is normal, his postprandial blood sugar is normal, and his HbA1c is less than 6. So in this case we can call it as a normal patient. So both as madam said, integrated or interdisciplinary interpathy medicines in collaboration, if we are working with modern medicine and we are suggesting some Ayurvedic regarding Shodhana Shaman and dietary changes,
Yes, sir.
definitely we will control the diabetes mellitus and we will control obviously the complications which are arising through the disease, and we will prevent the patients, we will prevent the pre-diabetes patient, or we will prevent the generation coming or who will lack the diabetes mellitus. We can definitely literate them regarding both Ayurveda and modern medicines. This is my view regarding the this case.
Thank you, sir. Very well said. Every aspect of Ayurveda and yoga is covered in your discussion. Thank you so much, sir. And
Thank you, ma'am.
extremely
Thank you
sorry
very
to all for technical issue from my side. And thanks to all experts for conducting very successful meeting. So next, to discuss homeopathic approach regarding diabetes, I will request Dr. S.P. Sharma from Shri Bhagwan Homeopathic College, Sambhajinagar.
Yes, good evening to all. Thanks, madam, for giving such a nice platform to represent all faculties. here nicely explaining that Dr. Madhuri madam has given. I'm hearable, yeah?
Yes, sir.
Yes, okay. So nicely explaining that what exactly the diabetes, how it comes, how it develops, and regarding that the classification and the symptomatology and so on by Dr. Madhuri madam. तो डायबिटीज क्या है, कैसा है, ये काफी अच्छे से हम उससे समझ सकते हैं, कैसा बढ़ सकता है वो भी हम समझ पाते हैं. Next, Dr. Anuja has representing that case, and the point of view from Ayurveda, she has explaining nicely. But with this, the nice explanation which should be given by Ayurvedic point of view by Dr. Naresh sir. And with that, the homeopathic concept when we will thinking, obviously disease appears when disease spiritual force is going to be affected. That is the basic thing which should be will feel from homeopathic point of view. So here the first victim is mind. Obviously that mind which should be affecting with the stress and the strain. Nowadays it's a basic factor what it affecting to all persons. And as that we know that diabetes mellitus, which is a metabolic disorder, which we call for polyuria, polydipsia, and polyphagia, and so on, says that it's a medicine, what it comes to know for. And with that, the homeopathic view, when we should be thinking, it based, जैसे आयुर्वेदा में आपके त्रिदोष है, वात, कफ और पित्ता. So homeopathic is also considering when diabetes, obviously it is a chronic disease, it is chronic disorder. It should be because of the three milestones what we considered, the psora, syphilis, and the psychosis, says that diabetes mellitus is a mixed or complex disorder with that psora syphilitic disorder. So naturally the psora, which reflecting with the mind to body to the less important organ to the vital organs, and as that insulin की कमी होना और उसकी वजह से डायबिटीज होना, ये उसका हो सकता है या होता है अपन जो कहलाएंगे. With this, that should be reflecting the psora, just the functional changes which arises the anxiety, depression, nervousness, and such a mental disabilities and mental conditions which developing further on with the symptomatic to the organ level, and disease goes from periphery to center. That is the basic concept what we should be considering from the homeopathic point of the view. And as that the psora is just a functional changes, and syphilis, that's one another the chronic miasm where destruction, degenerations, we should be reflecting with the organ level, and as that destructs some organ, and finally the psychosis, that is the miasm, which it reflecting for the what do you call the egotic or chronic suppressions, and obviously that chronicity we should be developing and with that symptomatology. So with this, Dr. S.P. Day, one of the homeopath physician, where he should be suggest that diabetes mellitus is secondary symptom of that psora. So psora, which begins from mind to body, which goes from periphery to center. At that time, we had to be investigate that case taking. We had to be interrogate that patient properly, and from that patient's proper history, whatever it should be giving, that the confirm the conclusions, and as that we come on the selecting the similimum homeopathic drug, and that's the basic principle of the homeopathy, where we should be prescribing the homeopathic medicine as per the law of similia, that's the similia similibus curanters. So much more medicines are there, but before going for that medicine, here some psychological conditions, just I have said in psoric miasm, where it should be ते सायकोलॉजिकल कारण काय काय असू शकतात, जे असायला हवं त्याची आस किंवा नियंत्रणाची गरज किंवा खोलवरचं दुःख, आणि सगळ्या साध्या सोप्या भाषेत आपण ज्याला म्हणतोय जीवनाचा गोडवाच नसणे, अशा प्रकारातनं पेशंट सांगतो. आता मनी वसे ते स्वप्नी दिसे या पद्धतीप्रमाणे ते आहेच नाही, मनात भावनाच नाही, आणि भावनाच नाही मग गोडवा निर्माण होणार कुठे, तशा प्रकारातनं सायकोलॉजिकल इफेक्ट त्याच्यातनं निर्माण होतात. पण याच्यासाठी नेमकं काय करायला हवं, तर एक सकारात्मक विचार हा सगळ्यात महत्वाचा. डाएट अँड रेजिमेन डॉक्टर सरांनी आता निंबाळकर सरांनी सांगितलंय, डाएट रेजिमेन, योगा, प्राणायाम आणि बरेच काही. तर त्याच्यामध्ये एक आत्ताचा जो क्षण आहे तो आनंदाने भरलेला आहे आणि त्याचाच गोडवा मी चाखत आहे या पद्धतीनं जर मी त्या पॉझिटिव्हली विचार केला तर तो गोडवा खरोखर छान वाटेल. पण याच्यासोबत जर होमिओपॅथिक औषधांचा विचार जर आपण केला तर त्याच्यामध्ये स्ट्रेस स्ट्रेन याच्या माध्यमातनं सोरा सिफिलिक सायकोसिस या माध्यमाच्या माध्यमातनं होमिओपॅथिक मेडिसिन्स हे त्याच्यामध्ये ॲसिटिक ॲसिड सारखा मेडिसिन आहे ज्याच्यामध्ये सिम्प्टम्स कोपियस वॉटरी युरिन त्याच्यामध्ये आहे. अर्सेनिकम ब्रोमियम हे एक सगळ्यात छान औषध आहे की ज्याच्यामध्ये 1x डायल्युशन्स मध्ये त्याला दिलं जातंय आणि देत असताना कॉन्स्टिपेशन किंवा अजून असोसिएटेड फॅक्टर्स त्याच्यामध्ये निर्माण होतात किंवा दिसून येतात अशा क्षणाला त्याचा वापर छान आहे. थायरॉइडिनम इज मेडिसिन व्हॉट इट शुड बी गिवन बट बेसिक ज्यावेळेस होमिओपॅथिक मेडिसिन आपण निवडतायत दॅट द टाइम वी गो विथ द सिमिलिमम ॲज that constitution that we should be considered constitution that should be reflecting that person as a whole and not only the physical but with the mental generals physical general and patient as a whole and at that time we treat the patient not the disease and from as that the condition we should be reflecting person to improve. So here another medicine the Seasonium zambolinum that is the mother tincture we should be prescribing here and that gives the excellent results as that medicine we call the जामुन या जांभूळ याच्या माध्यमातनं त्या मेडिसिनचा वापर हा छानपैकी मदर टिंक्चरच्या माध्यमातून होमिओपॅथीतनं होत असतो. याच्यासोबत नॅट्रोमूर दॅट नॅट्रोमूर पर्सन इटसेल्फ अ मेडिसिन फॉर द ब्रूडिंग टाइप ऑफ द नेचर्स ब्रूडिंग mental disabilities mental conditions anxiety and so on with this thuja that's reflecting with the psychotic miasmatic as that we call for the sora psychotic miasmatic conditions and in such a mixed miasmatic disorders that condition we have to be treated with such a medicine. One another the cyanothus is one of the medicine which reflecting the liver disorders and pre-diabetic state it should be treating so as that it's having also there the pigmentations and that insulin resistance patients with such conditions that we have to be treated here. Again, there are the arsenicum album, carbovage, graphitis, plumbum metallicum, phosphorus. Much more medicines are there, but that all we have to be given as per their the constitution. Constitutions means after the case taking, the proper history were to be investigated here, and that proper history should giving that proper selected simillimum as per their the principles of the homeopathy. That's the law of similia. And इसके अंदर में सबसे जो लिमिटेशंस हम बोल सकते हैं कि डिसीज इरिवर्सिबल कंडीशन में है ऑर्गेनिक लेवल पे है तो ऐसी कंडीशन में कोई भी पैथी हो कोई भी सिस्टम ऑफ मेडिसिन हो तो उसके अंदर मैं आपके संस्कृत का केवल एक श्लोक मैं यहाँ बताना चाहूंगा कि वैदेश तत्वम परिज्ञानाय वेदनायश्च निग्रहात् एतद वैद्यस्य वैद्यत्वम न वैद्य प्रभु संयुषितः. सो अर्थात एक बीमारी की जानकारी लेना ये डॉक्टर के हाथ में है और उस जानकारी के आधार पे उसको ट्रीटमेंट करना ये उसके हाथ में है. केवल वो बीमारी की ट्रीटमेंट कर सकता है, डॉक्टर एक भगवान नहीं हो सकता है. और यही शायद एक not only for the homeopathy but also for every doctor the science of doctors they are having the limitation and that's all from my side as per their the homeopathic. Thank you all and thanks Dr. Karle madam and all of you. Yes.
Thank you, sir.
Yeah.
Very nice discussion from homeopathic point of view. Thank you, sir. So now this platform is open for question answer session. If you have any query, you can ask to experts. The experts are here. Anuja, do you have any query?
No, ma'am, no.
No, ma'am. Okay, everything is clear. Okay. So we should stop here. Thank you so much, Dr. Anuja Bhosle from Sumati Vaishya.
Thank you, ma'am.
Thanks to our expert, Dr. Madhuri Kirloskar ma'am. She is professor and head from Dr. Vasantrao Pawar Medical College, Nashik. Then thanks to Dr. Naresh Nimbarkar. She is associate professor from CSMSS. He is associate professor from CSMSS, Ayurved College, Chhatrapati Sambhajinagar. Then last but not least, Dr. S.P. Sharma. Thank you so much, sir. He is professor and head from Sri Bhagwan Homeopathic College, Chhatrapati Sambhajinagar. Now we can stop here. Thank you so much to all audience for your huge response. Thank you.
Thank you, ma'am.
Thank you.
Thank you, ma'am.
Thank you, madam.
Have a nice time. Thank you.
I am sending feedback link. Just 1 minute. Please give us feedback. Okay, I will share feedback link on group. Please reply to it.
Okay, ma'am.
Yes.
Yes, ma'am.
Computer section.
येस मॅम
आपण ही मीटिंग थांबवू शकतो आता.
ओके मॅम ठीक
थँक्यू.